My name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. And today's event is co-sponsored by Academy Health's Health Workforce Interest Group, and it is entitled Innovative State Workforce Projections Models. Now, for those of you who don't know about us, we're HW Tech, and we're based at the Center for Health Workforce Studies at the College of Integrated Health Sciences, University of Albany, State University of New York. And our mission is to provide technical assistance to states and organizations that engage in health workforce planning. And so if you haven't already, check out our website at healthworkforceta.org. We have an extensive resource library of videos, webinars, reports, resource briefs, etc. And so by all means, while you're on our site, subscribe to our email list and you'll receive notifications for events like this. Now, this event, once more, is co-sponsored by Academy Health's Health Workforce Interest Group. And the mission of the interest group is to improve health and healthcare by promoting research and disseminating evidence that informs health workforce policy and practice. And you may join the interest group through Academy Health membership. And if you do so, you can use the listserv to share information about, say, your latest research, or perhaps you have a job posting for your university or company you'd like to share using the list as well. Both of those are quite fine to do. So if you're interested, by all means, contact Deborah Goldberg or Jeanette Deal. Now, this event is being recorded and it will be available on our website within the next couple weeks. And after the presentation, you may ask questions using the Q&A panel on your screen. And following today's event, you'll be asked to complete a short evaluation survey. So please take a few moments and provide us with your feedback. It would be greatly appreciated. And with that said, let me go ahead and introduce to you today's presenters. Today, we're joined by Yetty Shobo, the director of the Virginia Department of Health Professions Healthcare Workforce Data Center and Data Analytics, and Erin Fraher, a professor in the Department of Family Medicine at the University of North Carolina at Chapel Hill, and co-director, Program on Health Workforce Research and Policy, Cecil G. Shep Center for Health Services Research. Welcome, both of you. Yetty, would you like to go ahead and start us off?
Thanks, David. Good afternoon, everyone. I'm going to start by sharing my slide. Good afternoon. As David introduced, I'm Yetty Shobo. I'm the director of the Healthcare Workforce Data Center here in Virginia. And I'll be presenting the recent updates we did to the projection model we have on our website to you. I think anybody can do it. Most of what I used is based on what the National HRSA Center has. So the goal of my goal was to update the projections we have for some of the healthcare professionals in the state. Initially, we had used the HRSA model to do something similar like this. But this time around, I was thinking of doing it to the level where I also have it taken down to the regional level. So more than state and going down to the regional level. So first I had to think of what are my possible sources of data for demand and for supply. Demand is much more complicated for us. So some of my sources, my possibilities were the employment data from U.S. Bureau of Labor or the Virginia equivalent here, Virginia Economic Commission. But most of what they have is short and long-term employment projections. And for example, for nurses, what they will have will be just those that are nurses that are working in clinical positions and are working full-time. And I sort of want something that gives me the full picture of all nurses, regardless of whether they are working in clinical positions or not. So I couldn't use that. Another source would be the insurance data from the Virginia Claims Database, but I don't have access to that data. And also claims database usually does not, it's not exhaustive. It doesn't include all claims that are processed. So it's sort of it's not going to give you the 100% full picture. So next, my other option was the HRSA projection, which is well documented on the HRSA's website. And since I had use that data and that framework before, I reached out to the researchers I knew in HRSA, and then we talked about it, and I decided to give it a go. So this presentation will be based on that. So in contrast to my difficulty with demand, my supply data is very rich. Virginia has data on licensure, but we also collect data by survey, depending, the frequencies are determined by the registration, like the renewal, license renewal. So for some professions, it's annually. For some professions, it's every other year. For some profession, it's every other odd year or even year. So we have regular and very in-depth data on the supply part. In addition to having numbers of those of licenses, those in the workforce and the full-time equivalency units they provide, we also have data on the number of new licenses every year and expired licenses every year. So that was one thing that I said I was going to explore in this particular version of my update. Last time I did the projection, I didn't use that, but this time around I decided, since we had this very unique data, I was going to explore that. And the projection that I did is based on full-time equivalency units, which is the number of 40-hour units that is provided, either in a county or in the state. We use this because at times counting the workforce from our experience overcounts what you have available. So usually you could have, if you have 1,000 people in the workforce, but they're only working 30-hour week, then we are overcounting. So we like to standardize it and count, sum up all the hours that people report they work on average, and divvy it up into 40-hour segments to have full-time equivalency unit. So for my supply, what I did was I projected the numbers for the new licenses and numbers of licenses that expire every year for these professions, projected it out, got the equation of best fit, and used that to project out into the future. And then for my supply FTE, I used this formula that says, previous year's supply FTE plus, for this year, the FTE conversion. So I have like an FTE conversion rate that converts from the number of licensee and what proportion of that licensee actually, the proportion of FTE that comes from that licensee for each of the professions. So the FTE conversion rate, usually that is less than 1, because maybe one profession has people working more than 40 hours on average. Most professions have people working less than 40 hours on average. So usually it's a number less than 1. Then the difference between the estimated new licensee for that year minus the expired licensees for that year. And then when I projected, so I projected, but I also did some scenarios. So one scenario is a low growth scenario in which, let's say, we increase the number of new licenses by 3%, such as if we have like new enrollment initiative that brings more people in that particular profession. Another scenario that I explored is a high growth scenario where maybe we have a combination of delayed retirement and increased participation in the VA workforce. And what I mean by increased participation is, for most of our professions, not everybody that is licensed works in the state. So you have, like for physician, only 58% of our licensed physicians work in the state. So for that, if we could increase the percent of those working in the state, then we'll be able to also increase our FTE as well. And then the third scenario I used for supply was a scenario in which we're able to reduce the number of expired license by 3%, such as this one will be just maybe something through delayed retirement alone. For demand, like I said, what I use for demand is based on the HRSA adequacy rate, and HRSA calculated their adequacy rate by dividing their estimated supply by their estimated demand. So I use this adequacy rate against our own supply to get my estimated demand. For demand, I examined two scenarios, and one could always explore more. But in the scenarios I explored, one scenario in which demand declines by 3%, such as if we have better health behavior or initiatives that support people to have better health behavior in the state. And I also explored one in which we have increased insurance access, and that results in people having better access and therefore increases demand by 5%. So this part of it is a newly added version, and I'm still working on it, the regional estimate. So I'm looking at health districts in Virginia. We have 5 health districts, and I'm looking at it and dividing up the supply data and the demand data based on morbidity and disease surveillance data from the Virginia Department of Health. And so far, I've only done it for RN. I've not expanded it to other profession. But since I was able to successfully do it for RN, I believe I'll be able to do it for others. And, I'm going to vary what I do in this one by profession. So, for example, for dentists, I'll probably be looking at things like water fluoridation and dent and percent with dental caries in each locality. So it will be depending on the profession, the what I use to estimate the demand might differ. So the dashboard, the link has been sent on the chat, so I will not click on it. And most of what I'll be doing here, I'll just be showing you pictures from the website so that we don't have a technological glitch. So when you look at it, it's in form of a storybook. So most of the work I did were done in Excel, and then the visualization itself is done in Tableau, desktop. And so what we have is an introduction, setting up the stage and providing the link to the foundation that we use, which is from the National Center for Workforce Analysis, their projection model. And then the next page in the storybook more or less gives you the projection. And in this particular case, we are looking at registered nurses in the FTE for registered nurses in Virginia. So what you have is you have our historical data, which is this blue, and you can see we had this dip and then it's been more or less gradually increasing in the state. And then the dark blue line in the middle is the projection. This green line is one of the supply scenarios that we have, that you can see the legend over here. And we have two other scenarios here. So this scenario here is the low growth. The lower green is the low growth scenario that was explained earlier. And then the yellow and the green on top are the high growth scenario and the high retention scenario. So when we have a combination of reducing the number of RNs who retire, and also having initiatives where maybe we have a higher percentage of Virginia RNs working in states and not just licensed here. So that leads to this. But you can see for our RN, the supply definitely does not catch up with our demand. Our projected demand is this middle line. And the increased demand scenario where the assumption is that demand increases by 5% is this purplish line. And the scenario in which demand declines by 3% due to good health behavior that makes people more healthy and less likely to seek healthcare is this pink line. But regardless of where we look at it, whether the low demand scenario or the high demand far outpaces supply in the model for RNs. This is not for all professions. For some professions, we have demand outpacing supply. For some, we have supply higher than demand. And I will tell you which professions I have that for. So this is the new one. This is the breakdown for the regional data that I just added. It was still a work in progress. I just have the one for RNs here, and you can see the demand on this side and supply on this side. So more or less what you see is when it comes to demand, a lot of the demand is coming from this side of the state. Like we have a lot coming from here for the, I'm trying to look at this. I think I switched the two. So this is actually, this is supply and this is demand. I think I switched the two because supply is higher in this part of the state, but demand is higher in this part of the state up here. Um, and then I have this trend where you can choose to look at just two regions, and you can look at what the historical data is and how that historical data play out. But you can also see this. Here it's not, you don't see the difference in the line because I have all the five selected, but on the dashboard, you can pick just two or you can pick just one, and you'll be able to see the differences in the line because then you have everything mapped out on this. And it more or less explores the same scenarios that that I had looked at earlier as well. And you can play around with it on the website to see the demand, the supply. But I feel like this helps because people can see where demand is concentrated versus where supply is concentrated. And then for each of the districts, they can also see how things are going. Like for some district, the supply and demand are a bit closer. And for some, like the Southwest, you can see like demand is way high up here and supply is way down here. Whereas for some district, like the Northern Virginia district, you have closer, the lines for supply and demand are a lot closer compared to what you see for Southwest or what you see for Northwest. So empowering the people at the local level to be able to use this data as the best see fit. So the next thing we have on the dashboard is just definition of the different terms, definition of what is done and how it's calculated. I've not added much on the regional, on how I came about the regional estimates. That is something that will be added, but we have information on how things are calculated and all the methodological information needed. And so when I finished all this, when I finished it at the state level, I used a check. So I used historical data to see how the actual versus the projected data is. And this is an example using the RN. You can see that things are pretty close. In some years, I think 2023, we have more diversion. Like the number of actual is a bit higher than the projected. For most of the year, it's pretty close. All the estimates were within 4% of the actual when I look back and use the model to project to go back into the past. So limitation on some of this is right now, HACCP does not have data on all the professions I would like. And for example, with their behavioral health professions, the way they divide it up is different from how we have our data. So I'm still playing around with that to see how best I can use their adequacy rates for behavioral health providers. Also, I'm assuming a stable trend in some of this model, and we can only model what we know. I don't know if will be like a disruption like COVID that might make things go out of whack compared to what I'm predicting. But I'm predicting the future based on the past. But the how accurate my data, my model is will be determined by how much the future mirrors the past. Also, in some professions, in a couple of professions, you have demand and supply being related. So, for example, with RNs and LPNs, as we have LPNs moving on to RNs, so you have the RN supply is affecting the LPN supply and the RN demand. Like if we have, right now we have a decline in LPN in Virginia, you might have place of works where in the past they used LPN, start using RN. So which will create another demand for RN more than what I'm modeling currently. So that is something else to keep in mind. But in conclusion, I'll round up and say, the projection outcomes are very profession specific. For example, the 5% retention rate for RN resulted in the highest projected supply. But for APRN, it was a 3% increase in new licenses because I guess for APRN, new licenses are the main source pushing the growth for APRNs. Whereas for RNs, it seems as if supply is affected more by the people exiting and the expired licenses. So just reducing the expired licenses had more impact for RNs. Projected. So for some, like I said, currently I have 14 professions in the model. Projected supply meets demand for APRNs, dentists, occupational therapist assistants, pharmacy techs, physical therapists, and physical therapist assistants, but demand outpaces supply for dental hygienists, LPNs, physicians, RNs, respiratory therapists, physician assistants, and pharmacists. And like I showed, there is significant geographical distribution, and maldistribution explains things more than the changes over the years. So, when we look at some regions, like we saw for Southwest Virginia, have significant difference between what is being supplied and what is being demanded. So for those, you have huge, geographical variation across the states. Some parts of the states have it closer, whereas some you have a huge gap and a huge shortage. So this is what I have. I'm going to round up so that Erin can also present, and then I'll look forward to any question you have for me. Thank you so much for your attention.
Thank you, Yetty. I always learn so much from you every time you present, so thank you for that. I'm looking forward to sharing my slides, which actually dovetail quite nicely in places with your presentation. So I'm going to take a broad view of workforce modeling here and really talk about workforce modeling in the context of why we do it, right? To try to shape policy ultimately and to glean lessons from our models. So I'm going to tell you a little bit about our experience in North Carolina. So just quick disclosure, this work is supported by HRSA, by the AHEC program, the North Carolina Board of Nursing. Anything I say shouldn't be attributed to them or represent their official views. But I also just want to make sure that I give a huge shout out to the fact that this work really is the collaborative effort of the SHEPS Health Workforce team, present and past as well. We've had great collaborators and students as well. So as some of you know, I'm a big fan. In case your phone rings, dog barks, Amazon arrives. Here's what you need to know. States are an incredibly important locus for health workforce policy right now. I would argue even more important than they have been in the past. And we've really been trying to build models and health workforce data to make sure or to try to encourage decision makers to use data. And really what we're trying to do is translate our data into policy. And so with our models, with our data, we're trying to create a meritocracy of data, right? So stakeholders can identify gaps, they can identify, where, which professions, which places, and challenge narratives that are out there. We work really hard to strategically and intentionally frame the messages from our data and use data to evaluate workforce investments. We develop workforce models, as Yetty said, sort of you assume that the current trends will continue. And a lot of what she talked about, I just want to echo, is really simulating the effects of different policy options using scenarios. I also want to talk about how we've been leveraging, many of you know, we always joke about this. Whenever you go to the legislature, they say, yeah, so how is Virginia doing? How is Georgia doing? How's South Carolina doing? So we try to use our data to compare to other states. And none of this is easy, as you know, from your work. So why do I say states are increasingly important locus? If you actually, anybody remember, this was a report that came out of the Heritage Foundation in 2010, which was really, states are, they argued far better equipped than the federal government to address increasingly complex and serious healthcare workforce issues. We are in an era where we know that health workforce data are being actively debated, even more actively debated than it has been at the state level. And so thanks to the work of NCSL, Kelsey George and her team, that tracker really enables us to see that the number of health workforce bills enacted by states has risen dramatically, even in the last year, from 585 bills in 2024 to 851. So the data modeling that you're doing, the data collection that you're doing at the state level really is critical to informing this state legislation. So why did we develop health workforce data visualizations and models? As I mentioned, we wanted to create a meritocracy of data. The more we could create a level playing field for people and create customizable access to the data, the more likely people were to use data to figure out what was relevant to their profession, as Yetty showed, to their geographic area or to their specialty. We wanted to increase access and interest and engagement, and thanks to the work of Evan Galloway in our shop, you can download the data. So what we've seen is people taking the model findings off the website or the maps for their region or for their setting and really downloading it into presentations and using the data, which is really what we hoped for. Many of you are familiar with our health workforce data visualizations that allows people to explore and download data on now 27 health professions. I've included this because everybody who does data modeling knows that models are data hungry. And so having these longitudinal data that help us understand not only the numbers in the workforce, but workforce participation rates, the percent who are female, et cetera, is really critical to enabling us to do the kinds of workforce modeling that I'm going to talk about in a minute for registered nurses. I also want to point out that one of the things that we're constantly tracking in North Carolina is changing legislation. So some of you may be aware that North Carolina in 2023 passed an independent pathway for practice for certified nurse midwives. So now on our Viz, you can track our certified nurse midwives who are practicing under collaborative practice agreements. So under collaborative practice agreements with physicians, or those that are practicing independently. It will enable us to track those CNMs and figure out, are they practicing in different areas of the state? Are they meeting needs that once weren't met? This is sort of basic at the fundamental of workforce modeling, is sort of understanding where are people practicing and how do these policy changes affect supply. We also have new legislation for licensed psychological associates that looks very similar to our CNM legislation in terms of the requirements. So LPAs will also be having an independent pathway to practice. And so as in the future, we're modeling behavioral health workforce supply and demand, we'll be able to account for that new role of LPAs as we understand it. So it's not just about the data, it's how we communicate. So I just really felt like now was the time to put this quote in here. Really, more can be done to expand the scope of consumable morsels of evidence to house them in accessible archives to make sure that those with policymaking authority know where to look and how to access this information as they need it without nursing any delusional expectations of creating a new world of evidence-driven policymaking. So framing is really important. We spend a lot of time at our shop thinking about how to frame the findings from our models because the frames really do, in a moment, I'm going to give an example of this, shape how the findings are understood, right? And then those narratives then shape public opinion and ultimately government action. And I would say that I think we all agree we're living in a world where the power of narratives is growing. And one of the things our shop tries to do is use data to reshape and challenge prevailing narratives. So here's something. I met with legislators last Monday and I challenged them. I said, these are just descriptive data, but I wanted to challenge them. I said, hey, I didn't show them these data. I said, what do you think's grown faster in North Carolina, the population or physician supply? And to a T, they all said they thought that population had grown faster. And I said, actually, physician supply has grown twice as fast as population in North Carolina. The population's grown by 11%. The physician workforce has grown by 24%. Hospitalists have grown really fast. Family medicine at a lesser rate. But then I said, I also want to give you a heads up that general pediatrics grew at 8%. That's slower than the state average And that's a challenge for a state that's trying to develop a children's hospital. So one of the things we're trying to do in our modeling and in our data is try to anticipate, where is our state going? What data do they need to answer the policy questions that are going to be in the legislature in the next session and the session after that? Some of you have seen this. This is really where we talk about maldistribution, is this, even though we talk about this narrative, is helping them understand that our models, are projecting an increase in physician supply, that the gap between our rural and urban communities has continued to increase, even though overall supply, per capita supply, has increased. But that gap is widening rather than narrowing. One of the things you've seen us do is we go to the legislature and these are basic descriptive data, not even fancy models. We're just saying, here's the total number of North Carolina medical school graduates that have graduated between 2010 and 2019, because anytime we go to the legislature talking about physician issues, they say, let's open a new medical school. And so I say, okay, well, even with the addition of our fifth medical school, we've seen an increase in the number of new graduates from 415 to 628. We've seen an increase in the number who initially choose a residency choice in primary care. But look, folks, in practice, in primary care in North Carolina, we've gone from 67 physicians or graduates in 2010 down to 62. And the number practicing in rural primary care in North Carolina has declined. So we use these data in our modeling and in terms of helping legislators understand that it really is putting GME, for example, graduate medical education, in rural communities, and creating pathways from UME to GME that will, in fact, increase our retention. So not only do we track medical students, we track residents, and this is work led by Evan Galloway in our shop, where if you look at the retention of people who went to medical school and graduate and residency in North Carolina, you see that overall retention is 65%, and that's about double what we see for just retention if you did medical school out of state. But look at those retention rates for family medicine. 88% of our GME grads in family medicine who also did med school in state are retained in the state. And so we use these numbers to actually populate models, to populate data, to say, where do we need to create pathways and funded programs? And our legislature has picked this up in terms of creating pathways and bridges from medical school to residency. We always have to remind them that it's not just about physicians. So our models have to account for the rapid growth in nurse practitioners and physician assistants. You can see this is the cumulative growth since 2000, nurse practitioners growing by 509%, physicians by 33%. And we always have to point out that those NPs then are making up an increasing share of North Carolina's rural primary care workforce. So this is from 2017 to 2024. We were unable to collect data from the Med Board in 2020 and 2021. We got some data, but we needed to revise it. So we're holding it back. But you can see, in fact, that the percentage of clinicians in non-metro counties, and there we mean clinicians being NPs, PAs, and physicians, you can see the percentage in rural communities, the percentage of nurse practitioners is increasing. So we're thinking about what that means in terms of closing that gap in supply, what it potentially means in terms of developing interprofessional training programs in the state as well. So here's a model that I think some of you may be aware of that we developed called NurseCast. This was with funding from the North Carolina Board of Nursing, and in collaboration with our colleague Andy Napton from England, we developed this model on registered nurse supply and demand. And what it showed us, in fact, the baseline projection showed estimating a shortage of about 12,459 nurses in 2023. But 2033 rather, sorry. But that if nurses exited, as Yetty was saying earlier, you see a growth, almost a doubling in that shortage, up to 21,000 nurses. So this burnout, this exit that we're seeing in the nurse workforce really can drive our shortages in North Carolina. But one of the things we had to do is help the legislature and others realize and project scenarios. So what if we waved a magic wand and were able to create the infrastructure needed to increase faculty, increase space, and all of these things, and we could have a 10% increase in nurse graduates? Look, that shortage only narrows by about 2,000 nurses, right, in 2033. Whereas in the previous slide, you can see that retention is actually what drives the nursing workforce. So we're not going to, I always would say, we're not going to educate our way out of the shortage. We got to retain nurses because this is a way that we use our models to educate policymakers and help them understand where the biggest bang for the buck or the return on investment is going to happen for policy interventions. And so we did that, and when we presented it to the legislature, they actually decided to create a state appropriation and increase our nursing graduates by 50%. So we presented the data in 2022, and the legislature gave the UNC system money, which the UNC system then invested $29 million to expand its 12 nursing programs in North Carolina. So here's a direct line from our model to a legislative investment. And then we're thrilled that the UNC system then asked us to evaluate whether and how much an impact that $29 million in investment in terms of it's doing a couple things. It's developing new programs, expanding existing programs, reducing attrition, investing in simulation, and really looking at the degrees to which those interventions are going to result in increasing our nursing workforce in North Carolina. So not only developing models for projections, but then following that through with thinking through policy action and then evaluating the policy intervention. As Yetty said, we're really interested in looking at retention rates of nurses. This is an example of RN workforce exit rates. This was in a blog that we produced recently. And why I wanted to bring it up is to point out that we are transforming these cross-sectional data that we have to panel level, individual level data, so we can track career transitions and trajectories. And one of the things that we saw was the RN workforce exit rate actually increased, not surprisingly, during COVID, and then came down a little bit in 2023, but it's still hovering higher than it was pre-COVID. And this is really important data for us. To be thinking about retention, but also to be feeding our models in terms of understanding how are we modeling nurse exit from the workforce. We're also using data to monitor workforce trends after natural disasters. So one of the things we were called in to do was to analyze workforce supply for the 21 health professional groups in the 28 North Carolina counties that were FEMA designated disaster areas after Hurricane Helene. So what you're looking at the right are the number of professions even before Hurricane Helene hit, the number of professions in the county that had lower than the state average of that profession per 10,000 population. So we had many of our places already in the West before Helene hit that were lower than the state average, some very underserved, and some of them, those darkest counties, were places where it wasn't just one or two professions; it was all the professions in that we track had a much lower supply rate. So we're going to be looking at examining whether some of those people who we're going to basically be looking at comparing supply before and after Helene to understand, did people stay? Did they leave? Did they come back? And again, this will help us understand regional impacts because our state is very focused on post-Helene recovery in our western part of our state. We also use our North Carolina data to compare our North Carolina models to national workforce projection. So on the left, you see a comparison of our projection, what's called NurseCast demand and supply to the HRSA registered nurse demand and supply. A couple of things I think are really interesting about this is the supply actually tracks pretty much the same, but the HRSA demand is much higher that they projected than what we projected for both registered nurses and licensed practical nurses. And so it was really, as preparing for this presentation was the first time that we did this analysis. And so one of the things that we want to look into is the factors that are driving their model on the demand side versus ours. And demand is one of those things that's much higher, much more difficult to do. What we call backcasting is to sort of figure out what was demand versus what was projected. So I just want to say this work isn't easy or quick. You all know this modeling work, after you do the model, right, you have to invest time in crafting policy messages. And sometimes the messages require you to speak truth to power, as our friend Erin said in 1979, and that can be risky. One of the things, that takes time after you develop a model is drafting those policy briefs, giving people those kind of very simple descriptions, because we build these elaborate Maseratis of data visualizations, and they're beautiful to those of us who like to play with them. But most people who use those data just want you to interpret the data and frame it in the context of what they understand. And that takes skill, time, and shininess. And I'll tell you, a lot of times we get outshined because we're busy modeling. And policy change is frustratingly slow and incremental. But you know what? And I keep in mind that not all policy is driven by data, because Louisiana is the only state where florists are licensed. So sometimes you end up with an outcome that you weren't expecting. And the rationale is that without that, you could set up a situation where anybody could open a floral shop. So with that, I'll stop and we can go to the Q&A. I look forward to the discussion. Thanks.
Thank you, Erin, and thank you, Yetty. Those are very, very good presentations, and we already have some questions coming in. And just a reminder for those of you in the audience, you may ask questions using the Q&A panel on your screen. With that said, Yetty, we had a question come in during your presentation from Peter. He said, first of all, he really enjoyed the information you were presenting, but he had a small question regarding the supply and demand of RNs in the state. Specifically, if the current supply of RNs is around 80 to 90,000 and demand is 130 to 140,000, how is VA currently meeting the needs of the patients? Or in this case, is demand defined somehow differently?
Yeah, thank you so much for that question. I think that question is the reality that most states live in. That is the reality of most of the counties. You have definitely in Virginia, we have a shortage of nurses, and most health establishments will tell you they have a position that has been open for the past 3 months, 4 months, and they've not been able to fill it, or as they are filling one, another person is exiting and another open position. So more or less, that is the reality, I think, in most US states, is that demand, the number of professionals needed is higher than what we have. And that is why, people come up with all those policies in trying to respond to that. I think you'll be hard pressed to find a healthcare agency that says, oh, I have every single healthcare professional I need. Most of them either, have to have people working more hours than they need to or than are healthy for them, just to try to meet some of those demand that the supply is not meeting. So that is the reality, unfortunately.
Okay, thank you, Yetty. And actually, another question came in for you as well, and then we'll kind of open it up. We don't want to leave Erin out, obviously. But the dashboard you presented is for primary care workforce only. Is that right?
It is not. Thank you.
Okay.
It is not. So I have several professions in there. So for the physicians, it has all physicians. So one of the things I would like to do with the dashboard eventually is to be able to go and do maybe some specialty focus, but it won't be all specialties, because some specialties are so small that, and the licenses, the expired and new license numbers are not broken down by specialty, which is what I'm using to push the model. So, I'm limited in what I can do, but I would love to be able to do some more, break it down to some of the specialties that have bigger numbers and see what is happening with some of those specialties. But no, the number it's all physicians, it's all RNs, it's all APRNs, all dentists, dental hygienists, and pharmacists, pharmacy techs, and some of the other ones I have. I think I have PT and OTs as well, and then PTAs and OTAs. So it's everybody, it's not just primary specialty. I think the one we had initially was just primary PCPs, but then this new one is everybody together. Thank you.
And thank you, Yetty. All right. And this is really, I think either you perhaps can answer this one or take a shot at it. Don't you think a federal centralized data collection and integration system could better help design policies and manage the health workforce imbalances across the US within and between states?
Yes. Yes, if only we would be able to do that. I think the National Commission, the National Health Workforce Commission, remains a possibility as long as the ACA is the law of the land. And I have always been a fan of reading that legislation and Peter Warehouse and others' interpretation of that. And I do think it would really help with strategic workforce planning across states, across settings. We're also, though, incredibly lucky to have, and I'm not just saying this because they're on the call and they also fund me, but we do have amazing National Center for Health Workforce Analysis and within HRSA that actually is doing an amazing job creating dashboards at the national level so we can do the comparisons with state level. So that we are the envy of other countries that look at us that actually don't have a NICWA, don't have a HRSA. So I think in an ideal world, we would have a NICWA and a HRSA and a National Health Workforce Commission. So.
Thank you. Yetty, do you have anything to add?
I agree with Erin on that. So I agree with that. The HRSA is doing a great job with the center, and I'm benefiting from it, and I know so as several other states are benefiting from that. So yeah.
Yeah, and of course, and HRSA and NICWA is the TE Center's funders too. So shout out, thank you. All right. Once more, thanks for the great presentation. Any comments on the role of the new rural health transformation programs on state workforce planning? And, a big topic right now.
Yeah, thank you. Yeah, great question. Most states I think are just beginning to hit the ground running with the rural health transformation fund. So it remains to be seen. I'm very hopeful, very optimistic that we'll be able to see some of the rural urban divide that we see in the supply and demand, that we'll be able to see some of that narrowing. I know in Virginia we have several initiatives that are going to be funded by that. So that hopefully will help close some of this gap that we are seeing right now. But we also need to think of, like Erin and I, found in both of our presentation, an important part of the work with stemming the shortage is retaining people. So it's not just, our focus shouldn't just be on enrolling more students and creating more professions, but the people that are already working, how do we keep them from being burnt out, where they can stay in the profession longer and help meet the needs? So I welcome the rural funds, and I'm looking forward to the impact it's going to have on the rural areas of several of our states. I think it's a positive thing.
Okay,
Yeah,
thank you, Yetty.
thanks for that question, Lloyd. First of all, it's good to see you virtually, see your message virtually, Lloyd. But I think this is a really important question. And one of the things I've been thinking a lot about is this rural health transformation program is an example of the locus of workforce policy moving to states, right? The idea of it being to spur activity at the state level, right? And so that's, I think, a really important thing for those of us interested in workforce research and planning. The second thing I would say is it focuses a lot on patient navigators, community health workers, and others with whom we haven't spent as much time doing this kind of workforce modeling. And so it will be really important to build up our data infrastructures, our understanding of the roles of those individuals. The third thing I'd say is that because a good half the funding is going to come from these workload measures where you're actually going to show the impact. So can you actually do what you promised you were going to do? Did you lower your vacancy rate? Did you increase access to rural care? Did you increase supply? And so I say that in the context of I do think it raises the bar for accountability for workforce investments at the state level and puts the onus on us to actually have collected the data to be able to measure that impact.
Okay, thank you, Erin. Okay, comment followed by a question. This is from, I believe, Rick Brooks. I suspect that the current gap between supply and demand is met by a combination of understaffing, delays in access to care, overtime, and contract labor. Is there any way to measure any of these variables?
Hi, Rick. It's good to see you from Rhode Island, I suspect. Yes, I think one of the things that we can be doing is tracking vacancy rates, so understaffing. One of the things we've been doing at a national level, funded on a HRSA project, is looking at, for example, hospital staffing, nurse staffing. And one of the things you can see is nursing intensity. We had a Medicare paper showing that nursing intensity, that's nursing staffing relative to patient load, has actually gone down. We've also seen an increase in the use of LPNs in hospitals. And so I think you're right. I think you're on to sort of something, the next level of being able to monitoring the composition and staffing ratios and vacancy rates. And we could be doing a much better job, I think, measuring delay in access to care. Contract labor is really hard to get at because when we were using the AHA survey, it didn't have it. It now does collect some of that contract labor. So I think that those are really important points to be raising.
Well, I have another question then if you're all ready to move on to the next one. Actually, this one's from Michael Deal. He just gave a presentation, last December on modeling. And his question is, how often do you think legislatures and other policymakers use our models to help them define the problem and identify the most effective solutions versus use them to support their pre-existing problem definitions and solutions?
Yeah, that is an excellent question, Michael. And that unfortunately is what we have to, I guess, get better at based on what Erin presented, is get better at informing the people making the decisions, the power that be's of the existence of all the models we have, and helping them use the model, showing the power of this model is this data is there for you to use to help inform the policies you are making. I think more of what we see at times is them using it to support what the pre-existing definition that they have, but it's not being used as proactive as we would like it. So I'm learning a lot from Erin and some of the work she's done on how to take this and go the next steps of having the briefs, of having, telling the story so that the story doesn't just stay in my dashboard, but is communicated to not just even the legislators, but also, the average John that is in in all these communities that have, that I presented to look at and say, why do we have this gap? What can we do differently? So I think there's the huge onus on us to find a way to get this data model, problem solving tool into the hands of those that are making the decision so that it can be used effectively. Thanks for bringing that up.
Yeah, Michael, it's such a great question. Thank you. So when I met with legislators on Monday, Brianna Lombardi in our shop suggested, hey, we should use our models and our data and we should create individual fact sheets for the legislators. And so what we should do is grab the data from our data visualizations, grab the data from NurseCast, the projections, we have a thing called the grad diffusion tool. So you can see it where in their district, their education programs are sending their graduates. We do a thing called the primary care clinician index that looks at access to primary care in their regions. And so it took us, I'm embarrassed to say, a lot of our staff were working like insane hours trying to get those individual district level spreadsheets and fact sheets together. And it's creating these digestible morsels of evidence. And thankfully, the team was great, and we got it to legislators, and they loved it. Because it was different for people who had a district that spanned 2 counties. Cabarrus looked different than Rowan, not that but so it was really important to them and they thanked us. But the onus is on us, right? To go those next steps and say, here's what's happening in your county, and it might differ from the county next to you, and it looks different for different professions. And so it's that next step, and it takes time. This is the stuff that some, folks in consulting do really well. Like shininess is important if we're actually going to influence policy. And so we're trying to, but you know how it is. You're busy running models. It's hard to do the analysis and the policy briefs too. Great question.
Great. Thank you, Erin. And we're about 5 minutes till the top of the hour, and we still have a number of questions to go. Just so I apologize for those in the audience, we probably won't get to them all, but we'll get to as many as we can. The next question up, I believe, is a comment question on something we discussed earlier already. It's on the subject of federal centralized data collection. It seems to be a more viable option to create a nonprofit entity for states to contribute to a data model rather than have feds own it, considering current administration desires to dismantle federal systems. I wonder if an entity could build this by coordinating with states. Any comments?
I think it's an interesting concept, but I've not explored it. I've found places where it's worked, but it doesn't mean it can't work. Um, different countries have how they've approached the issue of data collection. We have a lot of countries where they have centralized data system on the federal level. I've not seen the one with the non-profits, but it doesn't mean it can't work. So
Erin, do you have anything to add, or shall we move on?
For me, the excellent question that raises 100 other questions, like
Yes, it's
what
kind
is
of
this what is this agency, and how does it collaborate with existing data sources, and how does it work? And so, yeah, no, I think it's an intriguing idea.
thank you. Thank you. Okay, and let's try to get to one more here. I was wondering, how do you take into account demand that is actually not responded to because there is a lack of workforce into your demand projection models?
thank you for that question. I think, like, the person pointed out, we will always have this demand that is not being captured. But the main thing is already, even with the ones being captured, we can't meet the need yet. So what we know is what we are measuring is the minimum, is more or less the minimum that there's still, the capacity is out there that is not being met is way more than what we are capturing right now. So currently we do not take account for that, but it is definitely there. And in the future, hopefully we'll find a way to get at that. I don't know how that will be captured in surveys or how it will be captured, but it needs to be captured that what we are currently looking at is the bare minimum demand and not everything.
Yeah, it's such a great question, and it relates to Rick Brooks' question, right? So, how do you measure unmet need? How do you measure? So, our models measure utilization often, right? But what is actually utilized demand? And so, this is the nature of how do you think about what the population should be demanding, or should be utilizing or needing. Sorry, let me get my verbs correct. What the population needs, given the age, demographic distribution, given their risk factors, given all sorts of things, and how do you measure that? And that's in fact a really important question, which is also related to how do we think about HPSAs and MUAs and other things? How do we actually think about operationalizing that, and what variables do we have, and how to? So it's one thing we've been thinking about in our shop, and so hopefully we'll have more information soon in collaboration with our NICWA and HRSA colleagues.
Okay, thank you, Erin. Well, unfortunately, I don't think we're going to get to all the questions, but that's just because it's been such an informative event, obviously. With that said, and this is to both of you, what's the one thing you'd like the audience to take away from your presentation today? What's the major take-home point?
Yeah, thank you everyone for attending. I think for me, the major take-home point is it's important that we drill down to local level, because if I had stayed on the state level, things look bad, but not as bad. But drilling down to the local level show that in some regions, things are really, really, difficult, and we need to find ways of meeting the needs in those regions. So the importance of drilling down to the local level, empowering those at the local levels to be able to get things done, I think is one of the things I want people to take home. And the importance of retention, focusing on retention. Like Erin said, I like her quote. She said, we can't educate ourselves out of this shortage. So we need to think of retention policies with the current healthcare professionals that we have.
Wow, one thing, David, I would say, first of all, thanks for coming in, and I really appreciated the opportunity to present and to push my own thinking forward. I would say, rock on, man. States are where the action's going to be, and so I think we need more webinars like this to learn from each other. What's happening in Virginia? What's happening in Utah? What's happening across the country? Because this is really where it's at, and so that's really my take home: is states are increasingly important.
All right. Thank you, Erin. And thank you, Yetty. And thank you, everyone in our audience, for attending today.